بسم الله الرحمن الرحيم. السلام عليكم. Welcome to weekly TLN-ICU program across the EHS. Today, inshallah, I'm going to talk about as a review, sort of review of the evidence on the postnatal corticosteroids use in the treatment of preterm infants. Most, of course, we are talking mainly here about chronic lung disease, so which I'm going to concentrate on in my topic. So I'm going to highlight during my presentation about the mechanism of action of corticosteroids, the side effects, the routes of administration, the timing of administration, controversies, some unanswered questions about the total dose we can give, about the timing, and of course, most of the talk will be about the evidence. So, bronchopulmonary dysplasia, it's the process is a chronic lung disease that's common in long-term morbidity in extreme preterm infants less than or equal to 28 weeks, and associated with increased risk of pulmonary hypertension, reactive airway disease, postnatal mortality, and adverse neurodevelopmental outcome. BPD is mainly secondary to inflammation that can begin in utero by chorioamnionitis, then postnatally by sepsis, mechanical ventilation, as you all know, oxygen exposure, intercurrent illnesses with necrotizing enterocolitis, and all of these will lead to abnormal lung development characterized by alveolar fibrosis. So, as we are talking about BPD, just we'll have a quick look about the definition. So it has went through many stages actually. All of us know that when you are talking about the PPD, chronic lung disease, you are talking about oxygen supplementation at 28 days postnatal age or 36 weeks postmenstrual age. So this is what you all know about the oxygen supplement. Now, this definition has been reviewed over the time. So in 2001, it was more of diagnostic criteria going through the grades of BPD according to the oxygen concentration plus the type of respiratory support we are giving, and it is very detailed. Then in 2016, this definition was revised again, and they concentrated mainly on, it was more specific related to oxygen concentration with the respiratory support. So let's say, then again in 2019, the latest review, it was subdivided into, so the BPD subdivided into mild, moderate, and severe. Then according to the type of respiratory support. So when you are talking about severe BPD, you are talking about a patient who is still on invasive positive pressure ventilation and still on oxygen FI2 equals or more than 21. If the baby he is on CPAP, non-invasive ventilation, or even high flow nasal cannula, so this is considered as moderate. And if the baby is just on low flow nasal cannula, 2 liters or less, then you are talking about mild BPD. The aim of postnatal steroids in those baby, of course, the inflammation plays a crucial role in the pathogenesis of chronic lung disease, for which corticosteroids have been widely used to prevent or treat chronic lung disease. So corticosteroids are potent anti-inflammatory agents. It decreases the lung neutrophil recruitment. It promotes anti-inflammatory cytokines and inhibits the inflammatory cytokines by genomic modification. So this is the pathophysiology of the action of steroids in relation to chronic lung. One of the most, the steroids, the use of postnatal steroids in neonatal medicine, actually it is one of the most evaluated intervention in neonatal medicine with different agents, doses, and timings. So the action here is it helps to facilitate early extubation. So how to prevent or treat PBD? It helps by facilitating the early extubation of preterm infant. It helps to treat steroids due to airway edema after prolonged intubation. It improves the pulmonary edema by diuretic action. It prevents, it even works also in prevention. There are other uses, of course, in preterm babies, but just to mention it in case of blood pressure management, adrenal insufficiency, and persistent hypoglycemia. So when and how to give? Postnatal corticosteroids can be administered by different ways and doses. It can be systemic, inhaled, intratracheal. It can be early systemic or late systemic. It can be early inhaled or late inhaled. It can be intratracheal with surfactant. Then we are going to talk about the dosages. Is it low dose, high dose steroids? And different types of steroids. We are comparing the hydrocortisone to dexamethasone. So we are going to go through all those ways of postnatal corticosteroid treatment in preterm infants in relation to chronic lung disease. Before that, we need to just pharmacology to know what are the types of steroids available using in the clinical practice, especially as parenteral administration. So the hydrocortisone, when you're talking about 20 milligram dosages, this is giving you the corticosteroid potency, glucocorticoid potency of 1 and mineralocorticoids potency of 1. Now this is your baseline. So the others you compare it to hydrocortisone. So prednisolone, it's 4 times more potent than the hydrocortisone, and it's mainly working on the glucocorticoid potency. Methylprednisolone, again, it's 5 times more potent than hydrocortisone. In relation to glucocorticoid potency, if you can just keep in mind that it has minimal mineralocorticoid potency both in methylprednisolone and prednisolone. Now, when you go to dexamethasone and betamethasone, it's very, very, very high glucocorticoid potency. It's 25 times more than hydrocortisone without any mineralocorticoid potency. This is very interesting to keep in mind. What are the side effects of the corticosteroids? As you all know, hypertension, hyperglycemia, cardiomyopathy, gastrointestinal bleeding, intestinal perforation, poor weight gain, and poor head circumference with extreme catabolism, susceptibility to infections, long-term complications related to the neurodevelopment, neurodevelopmental outcome, and I forget actually to mention also even osteopenia of prematurity. It causes also more resorption of bone. So means that whenever you are starting corticosteroids, you need to go and monitor all those possible side effects. So now we are going to talk about systemic corticosteroids. So postnatal systemic corticosteroids therapy, it helps, as we said, in shortening the time to extubation, reduces the need for re-intubation. It improves the short-term lung function and pulmonary outcome of infants with established PBD, and it reduces the risk of PBD in high-risk preterms. However, So this is, we are going to go more, elaborate more about the problems we are facing. So however, the systemic corticosteroid therapy, primarily dexamethasone, has significant short and long-term adverse effects, including neurodevelopmental impairment. So I'm going to mention with each statement what is the evidence behind it. So, and all those evidences are listed after the end of the presentation, so everybody can have a look on it. Now, when we are talking about early steroids, so they have studied using systemic steroids early, less than 8 days of life. So used mainly here for prevention, and they used the dexamethasone. So the Cochrane review, which was done in 2017, it includes 32 randomized controlled trials involving 4,395 participants, notes benefits with early extubation, lower rate of failure to extubation, and decreased incidence of BBD at 28 days of life or 36 weeks post-menstrual age. However, this strategy of treatment, it shows high GI bleeding, stent perforation, including increased risk of hyperglycemia, hypertension, hypertrophic cardiomyopathy, growth failure, but there was an also issue with major neurosensory disability. Then they try to study the systemic steroids when it is given late, means after the first week of life. So it is more mainly here for the evolving or established chronic lung disease. So another Cochrane review on, by Dolly on 2017, there was 21 randomized controlled trials involved with the participants of 1,424. It notes reduction again in neonatal mortality without significant increased risk of adverse long-term neurodevelopmental outcomes. But still there is a concern about the limitations of those studies. Actually, there is a long description about what are these limitations. So I just mentioned that there is limitations, which is already elaborated in this Cochrane review. Of course, there is reduction in failure to extubate, BBD, home oxygen, and death. But with this strategy, there is a trend towards increased risk of infection, hyperglycemia, hypertension, bleeding, without increased risk of neck. And there is here characteristically, there is increased severity in ROP, but didn't reach significant blindness. So therefore, late corticosteroids use should be reserved for infants who cannot be weaned from mechanical ventilation to minimize the dose and duration of any course of treatment. So this is the statement by the Cochrane review, and even it's mentioned in Gomella Handbook of Neonatology. Now, when you are talking about dexamethasone, so the steroids which we used to, which we are using usually is dexamethasone. There is multiple regimens described. What we are mostly used is the DART protocol. This DART protocol, just to elaborate it more, so it is a low dose for total dexamethasone dose of 0.89 milligram per kg. So this is the total steroids given over 10 days. The given data showed benefit without significant adverse effects for infants at postnatal age of 3 to 4 weeks who remained ventilator dependent. And this is the same author, Dolly, which was mentioned in 2006. Now, they tried to compare it to high dose. So this is, you are talking about low dose steroids of dexamethasone. They compare it to high dose. They try high dose. So the high dose is this is per day. So that was the total dose, 0.89. Here you are talking about the high dose, 0.5 milligram per kg per dose. It's high dose. It's associated with higher incidence of adverse effects, including adverse neurodevelopmental outcomes. So that's why it is not recommended according to Waterberg in 2010. So the dosage meta-analysis, there was 14 studies, not all of them are RTs, investigating dexamethasone. So in moderate versus high dosage regimen, it showed an increased risk of BBD and increased risk of abnormal developmental outcome when using a moderate cumulative dosage regimen. So there was no difference in death or BBD and neurodevelopmental outcome. There was no difference between the moderate and low dosage regimen. So these two RCTs investigating a continuous, another two RCTs was investigating a continuous versus pulse dexamethasone, and this showed increased risk of death and BBD. So when you are talking about other ways of giving the corticosteroids, just to make it easy, so the only used, and we can say that it is safe use, is the low dose dexamethasone, which is given over 10 days in a gradual weaning way, and when it is given at 3 to 4 weeks of age, when the baby is remaining ventilator dependent. Again, according about the timing of the course and the outcomes. So Harmon et al. At 2020 involved studies with participants of 951 in preterms less than 27 weeks, received the corticosteroids between 8 days of life and 36 weeks. So very, very late. So the risk of severe BBD was higher for infants treated after 50 days of life. Okay, compared to the a bit, let us say, between the third and fourth week of life. So the risk of neurodevelopmental impairment did not vary significantly by age of exposure. Now, when you are talking about hydrocortisone, so we talked about the dexamethasone, early, late, high, or low dose. Now we are talking about hydrocortisone. So early, low dose, this is systemic hydrocortisone. So the randomized trials of systemic hydrocortisone started in the first week, have found a reduced risk of PBD. The largest of these trials in Primiloc trial that compared a 10 days course of early low dose hydrocortisone to placebo and to check the neurodevelopmental outcomes at 2 years of age. Now, the BBD-free survival was improved and also the death was improved. There was no short-term or neurodevelopmental adverse effects. However, the subgroup analysis found higher sepsis rate among those most preterm babies treated with hydrocortisone. Another systemic review of 12 trials done by Morris et al. In 2019 with early hydrocortisone administration reported a modest improvement of the outcome of survival without PBD. However, again, the hydrocortisone group had a higher risk of intestinal perforation with concurrent treatment of PDA. So, in addition, data are conflicting regarding the neurologic outcome, with varied study designs regarding the timing, dosing, duration of hydrocortisone therapy, and gestation age of patients. So there, in these 12 trials, just the summary that they couldn't make it sure about the neurodevelopmental outcome. So you cannot depend on this dosage regimen because there is an issue with the safety regarding this major side effect. Now, when you are talking about the effect on growth, if you compare hydrocortisone versus dexamethasone, so Shastre et al. On 2018 showed that there is no difference in the growth between the hydrocortisone and dexamethasone group. at matched point time, and I'll go fast here. There was no difference in the growth parameters, but both of them resulted in decreased overall growth. And as per Williams et al. 2021, in whole population studied preterm infants with BPD compared dexamethasone or hydrocortisone for at least 5 consecutive days. Again, there is no much difference if you compare both the hydrocortisone and dexamethasone as effect on growth. Now, when you are talking about effect on lung function, according to Harris et al. In 2020, it includes a study with 159 babies, and it was noted that the prematurely born young people who received postnatal steroids may be at risk of premature onset of chronic obstructive pulmonary disease later on in life. Now, we covered all the types of systemic steroids, including the dosage, the type of steroids, and the timings. Now we are going to try to use more, let us say, more local steroids when you are talking about early inhaled steroids. So we'll see the early and the late or delayed inhalation of corticosteroids. So according to Shah et al. In 2017, with participants of 10 trials with 1,644 neonates, there was no difference in the incidence of BPD with the inhaled steroids versus the placebo. And there was a significant reduction in the incidence of chronic lung disease, also in death. It was noted to have lower rate of re-intubation in the steroid group, but no difference in the short-term complication between the groups. Also, there was no difference in the adverse effects at long-term follow-up noted. So it means that it didn't show that much benefit. Now, if they try to use the inhaled steroids late, after the first week of life. So according to Onland et al. In 2017, it was noted that attenuating pulmonary inflammation with postnatal systemic steroids reduces the incidence of BPD, but may be associated with increased incidence. Sorry, this is not systemic, this is inhaled corticosteroids. So incidence of BPD in preterm infants, but may be associated with increased risk of adverse neurodevelopmental outcomes. So the local administration via inhalation may be an effective, safe alternative. So they involved 8 trials with no reduction in death and BPD combined. The meta-analysis studies showed reduced risk in favor of inhaled steroids related to failure to extubate. I'll just go to the conclusion here. So the total number of randomized participants is relatively small, and most of the trials differed considerably in the participant characteristics. So it cannot be recommended at the moment. So you don't have enough evidence to show that the inhaled steroids, which is given late, can give any help in those babies. They try to use the intratracheal corticosteroids with surfactant. So when you give the surfactant initially, to give the steroids with it. So the aim here is to use surfactant as a delivery vehicle. It was also being proposed as preventive measure. There was 2 randomized trials from a single center using budesonide and at this dose mixed with surfactant, given intratracheally for babies less than 1,500 grams with respiratory distress syndrome. And this is shown to reduce death or BPD without affecting the neurodevelopmental outcome. Also, the meta-analysis suggests that intratracheal corticosteroids in preterm doesn't have significant long-term benefits. However, again, the data are limited to small trials from a single center, and the efficacy needs to be confirmed by large randomized multi-center trials. So as a result, it is suggested not to be routinely used for the time being due to limited data. So now the use of corticosteroids with the Strider. So systemic dexamethasone has been used before and after extubation to reduce the incidence of Strider. Now, presently, the Cochrane review on by Khimani et al. On 2009 states using steroids to prevent or treat Strider after extubation has not proven effective for neonates or children. However, given the consistent trends toward the benefits, this intervention doesn't merit further study, particularly for high-risk children or neonates. So we'll try to summarize. There is a lot of evidences here. So BBD is a disease of very low birth weight and extreme low birth weight newborns with multifactorial etiology like prematurity, ventilator-induced lung injury, oxygen toxicity, inflammation. The early inhaled corticosteroids, yes, it reduces the BBD, but increases mortality. The late inhaled corticosteroids has little effect. Systemic early corticosteroids reduce BBD but increase cerebral palsy. Late systemic steroids reduce BBD and mortality, but there was some, let us say, less or no increase in the long-term neurological impairment. It needs to have studies powered enough to pick up long-term neurodevelopmental outcomes. Very few studies compared the systemic to inhaled steroids, but found no superiority. The delivery of intrathecal steroids with surfactant is very promising, but the available data are conflicting, inconclusive. Hence, it is still not recommended. So you can see that there is uncertainty. What is the optimal regimen due to lack of consistent high-quality evidence, and due to differences in the study population, the type of the corticosteroid preparation, dexamethasone versus hydrocortisone, the dosage time and amount, the duration of the treatment, reflecting especially the cumulative daily dose, limited data on long-term neurodevelopmental outcome, and the use of rescue corticosteroids, especially post-extubation in babies to prevent edema of the upper airway with Strider. So this is the final few slides talking about the recommendation, which is present in many articles and even guidelines. And this is maybe the message which I want to deliver here. So as per American Academy of Pediatrics and the Canadian Pediatric Society, it is recommended not to use routine postnatal steroids, systemic steroids to prevent BBD for all extreme preterm infants, because using them to prevent BBD unnecessarily exposes a large number of patients who would not develop BBD to serious adverse effects of steroids. I think this is very clear, a very clear statement. This treatment is only reserved for exceptional infants with severe BBD who remains ventilator dependent on very high oxygen requirement, more than 50%. Such infants should first be evaluated for other causes of lung disease, including VAP, progressive pulmonary hypertension, or developmental of bronchopulmonary dysplasia. Parents and caregivers should participate fully in the discussion for risk versus benefits. And it is advised, if you want to give it as late, low dose, short course steroids as a 10 days regimen of DART protocol, which we are using commonly now. This is the most common protocol used at a postnatal age of 3 to 4 weeks. This approach minimizes the risk of adverse drug effects by providing a low cumulative dose of steroids to more premature infants. There is another approach described in the United Society in ICHD, and it works on, as the BBD itself is a risk factor for poor neurodevelopmental outcomes. So the problem may be not the steroid itself which causes the poor outcome, but it can be the BBD or the condition of the baby itself. So they try to reduce the risk of death or BBD or cerebral palsy by measuring the risk of BBD as a score if the risk is more than 60% at 2 weeks of age. There is a calculator for that if somebody wants to go through it. This is another approach which is not commonly used. This is my references. Thank you so much. I don't know if there's any question.
Thank you, Dr. Ahmed. Very nice presentation, comprehensive, and conflicting us more and more. So I'm not surprised with all of that. The floor is open now for any question from other centers, please.
As no more questions, we will conclude the presentation. Thank you so much for attending. Have a nice day. Assalamu alaikum.